Hi, everybody. This is Dr. Bill Curry again. Welcome back to our ACP video series about COVID. And we're really excited today to talk about treatment. We have Dr. Turner Overton from the UAB Division of Infectious Disease. Turner is a professor of medicine and infectious disease and is really one of the lead people about how to treat this disease, not only here at UAB, but across the state and nationally. So Turner, welcome. Thanks for talking with me.
Yeah, hey Bill, thanks for having me. It's really great. I've enjoyed collaborating with you by email during the epidemic here, and I'm looking forward to talking with you today.
Right, we've been looking at databases and talking about various kinds of treatment. So just to kind of frame what we're going to talk about today, we're going to talk about ambulatory treatment in the clinic or office or over the phone, virtually, however we're doing it, but not hospital treatment, because that is a totally different world. We have a lot of things going on over there. We have a remdesivir trial here at UAB. Looks like there's some promise with that. There's hydroxychloroquine and azithromycin on the inpatient side. We're going to talk about that a little on the ambulatory side. But Turner, we both became aware of this great JAMA article. I think we both have a copy of that diagram. This will be linked on the website. But it's a great article for internists or primary care physicians, family docs, because it gives a good overview of the mechanisms and the sort of the targets for treatment and gives you some rationale for treatment. So we'll recommend that. That'll be posted on the website. But based on that and on your own other knowledge and experience, what are the principles, Turner, of outpatient treatment of COVID-19?
Yeah, I think that's a great question. So like Bill said, 10 to 15% of people get hospitalized with this disease, meaning 85% of people are recuperating at home. And a significant number of them have symptoms related to the virus. And I think most of us are used to, fever, cough, shortness of breath being the big three, but there are a number of other symptoms. It's not uncommon for people to have GI symptoms, nausea, vomiting, as well as significant fever, leading to a lot of complications, and then myalgias as well. And many of these are related to the virus, but some of them related to kind of the cytokine release that we see, right, causing inflammation.
And that great loss of taste or smell.
Yeah, absolutely.
Too, yeah.
There's an under-recognition or under-appreciation of some of the neurologic manifestations, and I think a significant number of people have the loss of taste and smell.
Yeah.
I think, for the general internist, the first and foremost thing to be telling our patients is, just practical advice. First and foremost, telling people to stay well hydrated. I think that with the fever, with the myalgias, with the shortness of breath, people have a lot of insensitive water loss. And they have a tendency to get dehydrated. And in the setting of this infection, dehydration can lead to worse outcomes. So really trying to stay hydrated and telling patients, you want your urine to be clear. And so they really need to drink a lot of fluid. And that may seem like a silly thing to tell people, but I think it is really critically important that people stay hydrated when they have this viral infection.
Yeah, so those are great bits of advice. So there also are specific or sort of, I guess, general symptomatic treatment besides that, other sort of tips that you'd give us for that.
Yeah, so a couple of things. First and foremost, a significant number of people have bronchospasm with this illness and really benefit from albuterol MDI inhalers at home. So, I'm taking care of a large number of outpatients who are recuperating from COVID. And I find that people that report wheezing or bronchospasm really benefit from that. Similarly, a lot of people are having pleuritic chest pain from all the coughing. So giving a cough suppressant, particularly at night, can be helpful. Similarly, using Tylenol. There's a lot of question about whether ibuprofen should be used or not. There was some data from SARS-1 that suggests it could worsen the illness. We haven't seen that with SARS-2, and I think that for people who benefit from that, it may be a useful tool as well. But some of these traditional things, a cough suppressant, fever relievers as well as pain relievers can be tremendously important for improving symptomology for our patients. So, just because we have limited treatments doesn't mean there aren't some medications that can have big benefit for our patients.
Right, and that bronchospasm, I keep hearing about that. Of course, if somebody has asthma, it may be their allergies and it's this time of the year. But if they don't have asthma, they may get bronchospasm. And if they do, it clearly can be an indicator either way of worsening disease before they get to the severe dyspnea phase. So what about the alternative therapies like zinc and vitamin C and other kinds of trace minerals, things of that sort that have been out there that some people are trying? There's some basis for some of that. What do you make?
Yeah, there's very little data to inform those agents, but I definitely think that, antioxidants and immune boosters can be very, helpful in general. So, people supplement their diets with some of these vitamins a lot, but there is something to be said about eating fresh fruits and vegetables, and then supplementing with some of these shouldn't hurt. You do want to make sure if you take medicines that you're not taking something that's going to interact with one of your medicines, but definitely I don't think there's harm in most of those over-the-counter remedies as well.
Sure. Now I want to ask you the hot topic question, which is hydroxychloroquine, azithromycin. I mean, this gets talked from everywhere from the White House to everybody's own personal house about, what is the efficacy? Where's the evidence? What's the state of the art as of, this is April 16, and this is all a fast-moving target, but what's the evidence about hydroxychloroquine and/or azithromycin in this disease?
Yeah, so the interesting thing is there's some in vitro data that shows that both of these agents can reduce the time that virus is able to grow in the presence of these agents, and a significant reduction with just hydroxychloroquine that can be further reduced, in a test tube when you add azithromycin. So that's really compelling, what we would call preclinical data. There is some clinical data, so data from humans as well. There were a couple of studies out of France that looked very promising. Unfortunately, the data from those studies has been retracted because the research was performed in a very sloppy manner, and you can't trust those data. There is one small trial that came out of China that showed it was just a 30-patient study, but the hydroxychloroquine and azithromycin reduced the time of viral shedding and reduced the duration of respiratory symptoms in patients. So that's very small but compelling. It makes me a little bit nervous because at the same time, you may have seen a trial that was performed in Brazil where they actually gave chloroquine instead of hydroxychloroquine, and they gave quite high doses of
Big
that.
dose, yeah.
And there were 11 deaths related to the QTC prolongation in that trial.
Right.
So take a step back, the biggest concern about both of these agents, hydroxychloroquine and azithromycin, is that they both can cause QTC prolongation and then so lead to arrhythmias. So I think you need to be mindful if your patients are on any medicines that may similarly cause QTC prolongation, or if they have underlying, arrhythmias, that may not be the right patient for this combination. The FDA has fast-tracked these, and they have, approved them off-label, but I still have my concerns about them. I don't think we have enough data that compels me to use those in an outpatient setting. We have a trial that'll be coming up soon that will be fully powered. We're going to, over the United States, we're going to enroll 2,000 patients to hydroxychloroquine plus azithromycin or placebo as outpatients. We're trying to get it to them very early before they've had significant inflammation. And the goal is to prevent hospitalization and death. So if we can get it to them in the first 96 hours after the positive test, it can probably make a difference. And I think I'm very excited about this study, and I'd love to collaborate with our partners in the community who don't have much to offer for them to refer their patients to us if they're interested.
So thanks, and let me just point out, Turner, you're the UAB principal investigator for that arm, that arm of that site for this nationwide trial, and so you are the person that knows the most about it and the person to contact. We're going to post the information about that you'll give us. We'll post that on the website and Facebook for people who are interested. And remember, it's not available till about May 1. So, but just that's not as far away as it had seemed when they first started talking about it. So, I could be in private practice, you know, down the road in Alabama someplace, and I could enroll my patient in your study. The patient does the patient need to come to you, or can that be done remotely?
Yeah, so they have to come to Birmingham for the first visit, which is a screening and enrollment visit, and so that we can actually give them the medicines in the study. After that, all of the visits are remote. We do them by phone for the next 28 days, I believe. So,
Right.
you know, it is a little bit of burden for the participants who don't live here in Birmingham. But it gives them access in a very controlled fashion to the right dose of medicine and close follow-up as well by phone.
And just to emphasize, it is a randomized controlled clinical trial. So there will be people who get placebo
Yeah.
and others who get active drug.
The exciting thing about this is going to be the definitive trial to tell us if this combination of therapy actually does benefit people clinically. And then we can really move on from there. If it shows benefit, that'll be tremendous. And then this will be early treatment for anybody who shows up with a COVID test positive. You'll offer it to them. I fear that this virus is going to come in waves, as you've read about, over the next 18 to 24 months. And so we need to be prepared and have some treatments. It's really a frustration for providers to have very little to offer our patients when they come in unwell.
Right. Thank you. Yeah, because we're not going to be giving plasma infusions or probably remdesivir or things of that sort in the ambulatory setting. We need something. We hope this is it.
So
Yeah.
one of my partners, I'll just say, Bill, so this is exciting. One of my partners is actually leading our efforts on the convalescent serum. And while initially that's looking at inpatient, they're also looking at early outpatient. So can they give what's the right dose to give in an outpatient setting to prevent the complications? And whether that will be for a group who falls into high risk for complications or everyone, I don't know. But I think that you'll see over the summer and in the fall, we will probably open a trial for outpatient convalescent serum studies. And that, you know, monoclonal antibodies are cutting edge for so many diseases now. This is sort of similar therapy to that, except for it comes from someone who's already recuperated from the disease.
Right. That's terrific. Well, listen, we're out of time, but that was a lot of great information. Thank you. And again, thank you, Turner Overton, for being here with us. You're going to show us how to keep everything clean. Thank you.
Don't forget hand hygiene. Wipe down your surfaces. Make sure you use a mask.
Right. Yeah. Get a stylish mask. Thank you. All right. Here's my hand sanitizer. Thanks for being with us. Listen, if you enjoyed this video and others, like us on Facebook, follow us on Twitter, share us with your friends, get these messages out there while they're timely. Remember this trial, which begins May 1. We'll post that information. Thanks again, Turner, for being with us.
Thanks, Bill.